Looks good.
Okay. Hello, everyone. This is Fahd Alrumaih. I'm an emergency medicine resident. Today, we'll present the Censer study. And my objective today, we'll start talking about the background, hypothesis, methodology, and study design, result, and analysis, discussion, and conclusion, and then applicability. And let me begin by explaining why this study. So, as a clinician during an emergency, a shift in emergency department, usually we face multiple questions and we'd like to have answers. And one of the questions, when would be the best time to use norepinephrine in septic shock resuscitation? So the title for the study is Early Use of Norepinephrine in Septic Shock Resuscitation, Censer a randomized trial. And it was done in Siraj Hospital, Bangkok, Thailand, between 2013 2017. It was published in the American Journal of Respiratory and Clinical Care Medicine 2019. And their clinical question was, does early use of low-dose norepinephrine in adults with sepsis increases shock control by 6 hours compared to standard care? And to talk a little bit about background, previously, there are multiple observational studies have found an association between early pressors use and improved outcome. And all of us, or most of us, know that the Surviving Sepsis campaign have different targets and aims, mostly to measure lactate, do blood cultures, start broad spectrum antibiotics, fluids, and then pressors. And traditionally, patients with sepsis and hypotension are given fluid first. So the question rises, when would be the optimal time to introduce pressors therapy in patients with shock? And to follow the leads of PICO and PICO formula, so the target population, adult patients with a mean arterial pressure of lower than 65 and suspected infection, and those patients who were having shock for more than 1 hour, or any patients with having an active ongoing disease, which is a long list, like CVA, ECS, pulmonary edema, status asthmaticus, active arrhythmia, GI hemorrhage, pregnancy, seizure, drug overdose, trauma, immediate surgery, or advanced stage cancer, those patients were excluded. And regarding of intervention, low dose of norepinephrine, 0.05 mics per kg per minute for 24 hours, no titration. For a 70 kg patient, that would be around 3.5 mics. And the comparative would be placebo, D5 and water, and the primary outcome, shock control by 6 hours. So to define the primary outcome, those patients who had the shock control by 6 hours with a MAP of above 65 in 2 measurements, 15 minutes apart, or a urine output and a urine output of more than 0.5 milliliter per kg per hour for 2 hours, or a decreased lactate by 10%. And to talk a little bit about methodology, this study is a double-blind, placebo-controlled, randomized controlled trial, randomly assigned in a 1-to-1 ratio, and it was a single center between 2013 and 2017, and participants matched and balanced in their baseline characteristics and disease severity. Informed consents were obtained, and the patient's relative, attending physician, nurses, all were blinded in the study assignment. Further details, both groups and both arms of the study, both groups and both arms will following the Surviving Sepsis campaign guidelines. And if there is a failure to achieve a MAP of above 65 in each group, open label norepinephrine permitted. And to illustrate more the recruitment and randomization, they started with 456 patients were evaluated initially, and each arm by the end randomized by, in each group, 155, around 10 were withdrawn due to consent reason. And to elaborate on the results of this study, so this study have found that there is a shock control by 6 hours after the initiation of resuscitation. They found that there is a statistically significant in the early use of norepinephrine in comparative with the standard treatment. However, there is no difference found between placebo and norepinephrine mortality at 28 days. Following the results, there were in early norepinephrine group, there were achievement of MAB 65, urine output of 0.5, and lactate clearance. All these were significantly higher in the norepinephrine group. No difference in mechanical ventilation or renal replacement between each group. And in the arm of the norepinephrine use, patients were found to have less pulmonary edema and arrhythmia. And also in regard to intervention, they found that more open label norepinephrine were permitted in a placebo group, 80% versus 68, and fluid resuscitation was almost the same, 2.5 liter. And now let's shift our talk in about like strength and limitation. This is a first prospective randomized trial. It answers any really important clinical questions that will add to the literature. In regard to the methodology, such as allocation, concealment, blinding, attention to treat, complete follow-up, those were achieved, and participants matched and balanced in their baseline characteristics and disease severity. On the other hand, some limitation in the study that it was a single center that will decrease its role or its external validity. And the primary outcome was not patient-oriented outcome. And the secondary outcome, like all-cause mortality, was patient-oriented, but trial was underpowered for this outcome and can be considered hypothesis generating for future trials. Also, Robert will talk more about how to be more confident to state and rationale to state the rule of how to state a fact or how to state a result that you find more confident in. And lastly, to summarize this study, this is a double-blind randomized controlled trial that revealed norepinephrine administration at the beginning of septic shock resuscitation to be associated with higher shock control rate by 6 hours compared to the standard treatment. The Censer study gave us very good in regard of early use of vasopressor, so lend us to support the idea of vasopressor use in septic shock. However, there will be a range of clinical practices regarding the vasopressor till today and remaining till today, and which is acceptable. Future studies like CLOVERS trial, which have a high sample size with multicentre in regard of location, which will lead us to have more confident results, which might report in around 2021, and which will provide more definitive answer. And by that, I complete my slides. Thank you very much. If you have any questions, comments, I'll be happy to answer.
Great, thank you, Fahd. So people can put their questions in the chat box, and either we can answer them now, or maybe we'll just get back to them all at the end. So I'll just load up my my slides. Okay, so today I'm going to be talking about p-values and statistical significance. This is kind of a basic concept relating to evidence-based medicine, but is, I think, much more complicated than it can seem. But I think if you don't have a good handle on how to interpret p-values, what they mean, it's really difficult to actually understand a paper and understand what it's telling you. So the reason I chose this topic from the Censer study is because of this, this result. So the primary outcome was shock control by 6 hours, but I think the more interesting outcome is the mortality effects. So in the Censer study, in the placebo arm, the mortality was 22%, and in the early norepinephrine group, it was 16%. So there's a risk difference of 6%. I think most people would agree that a 6% difference in mortality is clinically significant. But in this study, the p-value for that outcome was 0.15, which by the conventional threshold of statistical significance would be considered non-significant. So it's a bit unclear when reading this trial is, can we interpret this trial as showing that there is a mortality benefit from early norepinephrine, or there isn't? And I think by understanding the p-value, we can get a little bit closer to understanding that. So what I'm going to go through today is to explain what exactly are p-values. I want to talk about why they have become somewhat controversial amongst a lot of methodologists and statisticians. And finally, to give you a practical approach on how to interpret them when you read papers. Okay, let's start off with some basics of the p-value. The p-value in simple terms is a way to quantify random chance. So you have two groups, as you do in any study, and you want to know whether the differences between them may have arisen simply from chance alone, or whether there is a true difference between the groups. By convention, we use a cutoff of 0.05, and if the p-value is less than that, we say that the result is statistically significant, which in other words means that any difference between the groups is not due to random chance alone. So I'll give you a fuller definition of exactly what the p-value is. So going back to our study, where the risk difference was 6% and the p-value was 0.15. So the formal definition of that would be, if there was no difference between the groups, there would be a 15% probability of finding a difference of this size, 6% or greater. And applying that same definition to the cutoff for statistical significance, we'd say if there was no difference between the groups, there would be a less than 5% probability of finding a difference of this size or greater. So it's a slightly convoluted definition. It starts with this hypothetical of saying, if there's no difference, then what's the chance of seeing a finding of this size? I think the simplistic way that most people then go on to interpret p-values is something like this. People think if the p-value is less than 0.05, that there is a true effect, there is a true difference between the groups. And if the p-value is greater than that, there is no effect, there is no difference. And so using that kind of simplified rule, you would say, well, in the Censer study for that mortality outcome, where the p was 0.15 and there's no effect, there's no difference between the groups. But for a range of reasons, I think that's an overly simplistic interpretation. And to understand why that is, I think we need to spend a bit of time going through the controversies about the p-values and why some people think we should put less emphasis on them. So in recent years, there have been lots of articles and opinions criticizing the p-values. This was the first thing I've got up here was a letter signed by over 800 statisticians and researchers, basically calling for us to stop using p-values and to use alternative measures. A couple of years ago, a big journal in the world of political science decided they were going to stop using p-values altogether. And then this last quote here is from the editor of the journal Epidemiology, which is the highest impact journal in epidemiology, who for many years had a policy saying that they did not want anybody to use p-values or use the term statistically significant. And when somebody did, this is what he wrote to them in a letter. I ask that you delete p-values as well as comments about statistical significance. If you do not agree with my standards, feel free to publish elsewhere. So that's quite a striking, strong opposition from somebody who is well respected and a kind of a leading thinker in the world of methods and stats. So it's important to understand why the p-values are so controversial. Now, a lot of the criticisms of p-values are slightly obscure and not super relevant to clinicians, but I want to focus in on 5 criticisms or controversies about p-values that I think do have some relevance to us and may help you understand and interpret them. So first up, and I think most importantly, statistical significance is not the same as clinical significance. You can have a finding which has a p-value of less than 0.05, but is for a difference which is not clinically significant. So let's just look at this example. Let's say you do a study. Maybe you're looking at the effect of POCUS on a given condition, and your outcome is ED length of stay. And you find in the control arm, the length of stay is 3 hours. In the intervention arm, it's 2 hours and 55 minutes. So you've saved yourself all of 5 minutes. But you have a big sample and your p-value is really small, 0.001. But is that really a useful intervention? I would argue probably not. Or what about our study? You have a 6% mortality difference, but the p-value, which I think is unquestionably clinically significant, but the p-value is non-significant. So is that a useful study? That's harder to say. Issue number 2, or controversy number 2 about p-values, is that sometimes they will be non-significant, not because there's no difference between the groups, but because the study is underpowered, i.e. it does not have enough subjects in the study. So looking at the Censer study, they had a sample size of 310. That gave them that risk difference of 6%, but the p-value is non-significant. If they had doubled their sample size to 620, with exactly the same effects, now the p-value would be significant. Now, you can't simply say, oh, well, if they just double the study, then we'd have a significant effect. You don't know what would happen if you double the size of the study, but this is merely to illustrate that p-values are determined both by the size of the difference between the groups, but also how big your study is. And often you will see a non-significant p-value, not because there is no effect of the drug, but simply because there were not enough people in the study. And that may be the case in the Censer trial. The third major criticism of p-values and statistical significance is that 0.05 is an entirely arbitrary cutoff. I mean, essentially, sometime in the early 20th century, some guy decided that 0.05 seemed about the right number, and since then, it's stuck. But that leads to this kind of somewhat irrational or arbitrary belief that if your p-value is 0.049, that you have a true difference between the groups, but if it's 0.051, it's not. The truth is the p-value should be interpreted continuously in the same way that you interpret test values. If somebody has a white count greater than 12, technically have the leukocytosis, and if it's less than 12, they don't. But we all know there's not really much of a difference between 11.7 and 12.2. You interpret this on a continuous scale like you would a clinical value. The smaller the p-value, the lower the chance that this is a random difference, and the larger the p-value, the greater the chance that it is. But there isn't really much difference between the 0.05 or 0.04 or 0.06. Issue number 4 with p-values. They only measure random error. They don't quantify bias or imbalances between groups. Now, in a randomized trial like Censer, that's not as much of an issue because a well-designed randomized trial, which I think Censer was, should not be subject to that much bias. In other words, the groups are well balanced. But especially in observational and retrospective studies, if you're fixating on the p-value, then you're not going to be paying attention to, you're going to be missing on all the other reasons why your study might be misleading or wrong. Things like confounding, selection bias, measurement error, missing data, publication bias. By fixating on the p-value and this magic threshold of 0.05, you can forget there are all sorts of other reasons why a trial might be incorrect or has some other issues. Okay, finally, controversy number 5. The p-value doesn't really quantify what we want it to do. So we spoke a bit before about what the definition of a p-value was, and it was this slightly convoluted thing of saying, if there is no difference between the groups, then this is the chance of seeing a difference of this size. I'm just going to test if people kind of retain that. So let's go back to our study, risk difference 6%, p-value 0.15. So many people interpret that as meaning if the difference in the study is 6%, there is a 15% probability that that's a chance finding, or in other words, that the true difference is 0% and this is just a chance finding. That's kind of, I think, what people would like the p-value to be, a direct quantification of whether this is a chance finding or not. But in fact, the correct definition is the other way around. The correct definition is, if the true difference is 0%, there is a 15% probability that the difference in the study will be 6% or greater. So it's kind of the inverse of the probability that we actually want to see. Okay, so to summarize those problems, statistical significance is not the same as clinical significance. P-values can be non-significant simply because of insufficient power and not because there is no difference between the groups. 0.05 is an arbitrary cutoff. P-values only quantify random error and they don't quantify various sources of bias. And finally, the p-value definition itself doesn't really quantify exactly the thing that we want it to. All that being said, papers still use p-values and you need to have a practical approach to understanding and interpreting them. So that's what I want to cover just in this last section of the talk. Okay, so first up, this issue of statistical and clinical significance. The idea of clinical significance really is a question of judgment that only a clinician can judge. Do they consider the difference between the groups to be clinically meaningful? So let's say you read a paper and it is statistically significant, i.e. the p-value is very small, and it's clinically significant, the difference between the groups you think is meaningful. then that's simple. That's an intervention that you should think about using. If you're in a situation, as we are in the Censer study, where it is not statistically significant, but the difference between the groups is potentially clinically significant, then you can't really say that the treatment works or not. You can speculate that maybe the trial is underpowered, but essentially what that means is that you just need a bigger study to answer the question definitively. And I think that's the correct way to interpret Censer. It certainly provides evidence that early norepinephrine may be beneficial, but we can't definitively yet answer the question. But what you can't do is say, oh, there's no effect. The third scenario would be you have a study where you have a statistically significant effect, but it's not clinically significant. In that case, I don't think that should change your practice. And then finally, you can have a study which is neither statistically or clinically significant, and that study should definitely not change your practice. Next thing to bear in mind, interpret the p-value in a continuous way. Don't get too fixated on this arbitrary cutoff of 0.05. If there is something for which there is already a lot of evidence, and a study comes along and the p-value is 0.06, then there's probably still a true effect of that intervention. If, however, there is an intervention for which there is lots of evidence showing it doesn't work, there is no plausible mechanism, and then somebody publishes a study showing an outcome with a p-value of 0.04, then it probably still doesn't work. You have to combine your prior probability with the p-value. Now, the smaller the p-value, yes, the more likely there is a true effect, assuming there is no bias. But nevertheless, you have to combine the p-value you see in the study with what you already thought and what the existing evidence showed. And finally, in an observational study, this is less an issue in randomized trials, but in observational retrospective studies, random error is only one source of error in a study. The p-value only quantifies the random error. You have to think about all those other sources of bias which are not captured by the p-value. So in summary, when looking at a p-value, ask yourself, is this effect clinically as well as statistically significant? Does this study have enough power, i.e. are there enough people in the study to find differences? What was my prior probability? And try and update that with the p-value that you get. And then finally, are the differences, in addition to random chance, is there any issues of bias in the study? Okay, so that's the end of my talk. I'm just going to open the chat window to see if there were any questions. Okay, so just a couple of comments which I'll read out. So Nicholas Selt says the Censer was included in a recent meta-analysis which supported the conclusions. So that's good to know. One of the advantages is when you have small studies where the p-value is insignificant, what you can then do is try and find other small studies, and when you pull them together in a meta-analysis, you may then find that the result is significant, and that's seemingly what has happened. This was a study published just a couple of months ago. So that does lend support to the idea that early norepinephrine really is beneficial. And then Josh says, an additional variable I've included in this decision matrix is ease of intervention. Yeah, that's very true. So in addition to, you may potentially have something which produces a clinically significant difference, but which is incredibly impractical or expensive. And conversely, you may have something which has a very small effect, which is not that clinically significant, but if the intervention is very cheap and very safe, then you may still want to do it. Okay, so let me see. So Mariam asked, is there a new method that will replace the p-value? There are other statistical tools which people have proposed as alternatives to the p-value. Some people think of using the 95% confidence interval as kind of an alternative to p-value. I think there is some merit to that, and you do get more information from the 95% confidence interval, but ultimately, people end up interpreting confidence intervals in a similar way to p-values, in that if the interval doesn't include the null, they say it's significant. And again, you run into problems of arbitrary cutoffs. There's a whole other group of statistics called Bayesian statistics, and they have something called a Bayes factor, which is similar to a p-value and I think is actually much more useful, but it's not yet in widespread practice. So it's probably going to be quite difficult to learn about it at the moment because you will not see it used in many articles. Okay, so I don't think we have any more questions. Our next speaker is due to be on in about 10-15 minutes. So why don't we take a 10-minute break and come back at 9:45. Okay, hi everyone. So our next speaker wasn't actually due until about 10 past 10. So perhaps we'll just extend this break out to 10:05, which will give him plenty of time to sign on. So see you all back here at 10:05.